Yeah. So this will be a short clinical station on assessment of lower limb neurology. There's a who's going to be taking, who's going to be presenting.
Yes, I will do.
All right. So you are asked to assess neurological assessment of the lower limb for a 14-year-old boy who has come into the clinic on a routine follow-up check. So yeah, you can start. I will start the timer now.
Okay.
So I've started the timer. If you think you've got enough, then I'll stop the timer and we can go ahead. So that the earlier you have you've got everything in place, the better it is. Try to go through in your mind during this 4 time. Try to make good use of this 4 minutes. That revise your examination as quick as possible. The examination should be at your tips by this time in your actual exam station, and try to list what are the possible cases, what else could you get, things like that. And also, just to give you guys a side note, when you ask to assess any neurology of the lower limb or the upper limb, it doesn't mean that the pathology or the problem will just be limited to that limb. So it could be a wider pathology, wider problem, but you are not expected to do or assess the other aspects in this station. You will lose your time, you will lose your marks.
Okay.
Okay, so this is important, because when you are considering the list of conditions and diagnosis, so that you are not thinking just something that just involves the legs. All right.
Yeah. So first of all, I wash my hands, and then I'll start with my introduction that I am Dr. Aisha, one of the candidates who is. How may I call you?
Yeah, so you can call me Joe.
Joe. Okay. Joe, are you all right?
Yeah, I'm
If
good,
I
thank you.
examine your, if I examine you, if you feel any discomfort during the examination, you could let me know. Okay.
Yeah,
If you feel
okay.
sore anywhere, you can let me know. Okay. So
Yeah,
I'll stop at that point. Okay. So Joe, would you like to walk for me in this room?
yeah. Where do you need me to work?
Yeah. If you can walk from just this
Yeah.
point to
So
the
yeah,
door.
yeah. So that's right. So Joe is walking from one corner of the room to the other corner, and
Yeah.
you can see that he's walking slowly, and and it's a bit asymmetrical. Both the limbs are a bit asymmetrical.
Okay,
His
so I
when
would
he's
like to
walking.
observe what sort of gait it is, whether it is a hemiplegic gait, like is he moving his one of the leg in circumductive way, and also whether that side of the arm is flexed or not. I will see for that.
Okay. So how would you like to do? Would you like to do any maneuver to check that out?
Uh, uh, I think I don't remember any maneuver for that, but maybe tandem walking would usually demonstrate the ataxic gait. Uh,
Yeah,
mm,
that's fine. So you have when you observe him from head to toe, you can see that his arms are flexed. One of the right side of the arm is flexed, and he seems to be dragging his right feet.
okay.
Yeah,
Okay, so that's
intermittently,
fine. But
slightly.
I during this procedure, I would also be careful that the child should not fall. So I will be with him, like while
Yeah.
also observing him. But I will be with him
Okay.
when he's walking, and
Yeah.
then I will say him to just sit on the chair, and I would like to, and also I will observe what sort of aids he's having. Is he having any hearing aids or any dysmorphic features or any neurocutaneous stigmata, any vision or hearing aids? Then I would start with the inspection of the legs. Like I
He's
would,
got he had come with a walking aid, walking stick.
okay,
So that's
walking
fine.
aid.
Yeah. Yeah.
Okay, okay, that's fine. Okay,
What else would you like to do?
and then I would like to expose his legs, and I would like to see the bulk of the both of the legs. Is it symmetrical or
So you
asymmetrical?
can appreciate that there's a wasting on the right side of the leg compared to the
Okay,
left side, and there
Mr.
are no scars. There are uh, no other marks of relevance.
Okay, then I would like to see the tone, whether the tone is like I would like to see the passive, check the tone of the lower limbs by rotating every joint passively to see whether it is hypertonic or hypotonic. I would like to check the tone of both limbs, and so I
So
would
there,
like to know.
yeah. So you can when you are moving the joints, so you can see that there is a tone variation. There is a mixed tone. So on the towards the end of the movement, it's a bit, you can appreciate a catch. So there's slightly hypertonia.
Okay, hypertonia. And then I would go for the I would like to check the power of the lower limbs. So I would ask the Joe, so okay, I will could you please pull my hand like I will tell him that I am going to press your legs down, but you have to you have to try to move your legs away from my, like you have to pull my
So
hand.
what position would you like to keep him in?
Yeah, then
Yes.
I would like to make him lie down on the
Mm-hmm.
bed,
Mm-hmm.
and then I will try to assess the power on each of the muscle group. First of
Okay.
all, I will try to assess the power of the legs, and I will say him that Joe, I'm going to push your leg towards the bed, but you have to try to you have to try to lift your legs,
Okay.
uh, and then I will assess how is the power of the both the legs, and then
So
yes,
yeah, go on. So when you are doing this, when you are asking Joe to lift
yeah,
the leg and you are applying a bit of resistance, so you can see
yeah.
that there is a asymmetry or less power in the on the right hand side, where you have appreciated the wasting of muscles. So the child is not able to lift that leg against resistance, although he is able to lift without resistance. Uh, yeah.
Okay, then I will see how is he able to adduct, or I will see the power of adductors, abductors, also the power of hip muscles, proximal
Okay.
muscles, like whether he's extensors and flexors. And then after assessing that, I would after assessing that I would like to see the planters, and I would like to see the clonus in this
Okay.
child.
Yeah. Yeah, so there is, as I mentioned, when you assess for the hip flexors, adductors, and abductors, there's the similar pattern of power. You can see it is um, against resistance, the child is struggling, but
Mm.
without resistance, the child is able to do the complete range of movement.
In both the limbs or just in the right
In the
side?
right, in the right side, in the right side.
Okay, while the left side the power is normal,
Yeah,
against the resistance it's
yeah.
normal.
So,
Okay.
so sorry, one second. Six minutes is up. I'm not sure if we have got 6 minutes or 9 minutes. Is it warning at 6 minutes,
Six
and then
minutes
we'll go
for the
through?
examination and then
Sorry.
3 minutes with the examiner. It's 6 minutes for the examination and 3 minutes with the examiner.
Okay. So what I'm going to do is just allow you some more time, because you are verbalizing. You are not
Yeah.
actually doing the examination. So I would allow you some more time to complete your examination, and then we'll move on to the discussion. Okay. And
Yeah.
yeah, so just continue. So you have done the the power assessment of the
Yeah,
abductors,
just the
flexors.
reflexes are left, so I would like to check the reflexes of the planters and the knee jerk in the lower limb.
Okay. So when you check the reflexes of the deep tendon, reflexes of the patellar tendon, you can see that there is a exaggerated brisk reflex even at the ankle joint, at the Achilles tendon.
Okay.
And the Babinski is positive. Babinski is absent.
Lewinsky is absent. Okay, then I would like to see the uh, any obvious. I could also check for the cerebellar signs like heel to shin test as well,
Yeah.
and I would also like to go for the quickly. I would like to see the whether there is any obvious cranial nerve, like any cranial nerve lesion, like the facial nerve. Is there any facial asymmetry? Or I would quickly do
No,
the
no,
edge.
no, no, no. No, don't go beyond the lower limb at this point. I mean, this is just try to stick to the
Okay.
lower limb neurological assessment, and then in your closing remarks, you say that I would like
Okay.
to do a complete neurological assessment, including the upper limb neurology and the cranial nerve assessment.
Acha, because I thought that I have to do everything in this.
When I said first that it's the lower limb, specifically, so read the task very carefully and try to stick to the task. Okay. And don't deviate away from that, because the exam station is designed only for the task. Okay. You will be the time will be up quite soon, and then you will lose your confidence that you have not done this and that. But in fact, you were only required to do a neurological of the lower limb.
Okay. So.
Okay, but I mean, if you got time, if you had the time, I would say you could do sensation of the lower limb.
Yeah, I have written it. I would like to see the sensation, bladder, back.
Yeah, instead of going instead of doing upper limb or cranial nerves or even abdomen as such, try to do the sensation of the lower limb if possible.
Okay. Yeah, because I was thinking that my time is going to, so I have to see the all other things as well. Okay.
No. Yeah.
Okay.
So yeah, if you could just go through the sensation, how would you be testing the sensation?
So I will check on the dermatomes, like near the plantar surface. I think it's S1, plantar surface of the foot, and then on the legs L2, medial surface, then on the knee L3, L4. I have not memorized it properly, but I have to memorize.
Fine, no problem. We'll go through this. So yeah, can you summarize what, based on your assessment, based on your examination findings, can you summarize what have you found and what's your impression?
So Joe is a 14 years old boy who is having uh, a circumductive gait on the right side, and he's also have a walking aid. And on the examination of the lower limbs, I found that he's having an upper motor neuron lesion, as his findings were consistent with the increased tone in both limbs, and more on the right side, and power of 3 by 5, decreased power 3 by 5 on the right side, and also wasting of the muscles of the right side, and the reflexes were brisk, and Babinski's were absent. I would like to complete my examination by doing the cranial nerve examination, upper limb examination, and higher mental function test as well.
Okay.
And this could be the.
And what do you think? Yeah, what do you think could be causing this?
So this could be a hemiplegia. Secondary to underlying reason could be any infection, or could be due to stroke, could be vasculitis, or could be any neurodegenerative disorder, or I would like to ask in the history as well whether is anything related with a birth related issue, or like hypoxic.
So what are the causes of hemiplegia at this age? I mean, when you see a child at this age, and and the child is coming with hemiplegia, and what do you think it's an acute hemiplegia or it's a chronic hemiplegia? And what do you and how do you say that?
I would like to take the complete history, because it will help me in narrowing down my differential diagnosis.
Yeah. So based on your examination today, based on your examination findings,
yeah,
what do you think it is? Is it a acute or a chronic hemiplegia?
I would also like to, because there is a wasting as well.
Good.
So this could be the chronic. Yeah, this could be the chronic ongoing problem. And but if there is a but the causes of hemiplegia are very wide. So they could be because of any hematological problem like sickle cell, or any malignancy, or or any autoimmune or any vascular like moya.
All right. So, how would you proceed, and how would you manage this case at this point?
This will need a multidisciplinary approach. I would like to take a history, and then I would like to take a full sets of vital, blood pressure, and carry out the rest of the examination. And we will take pediatric neurologist on board as well. And then we will go for the full blood count in order to see any blast cells or any sickle cells, and the TLC count, and autoimmune workup, and also would like to arrange an MRI scan of the head, and any like thromboembolic phenomena like protein C or protein S deficiency, or also I would like to check for the urine, like sometimes although like it will be the history will mostly suggest like sometimes a nephrotic syndrome, or also these conditions can also lead to the thromboembolic phenomena and hemiplegia. So I would like to take the like urine DR, full blood count, autoimmune profile, and MRI scan, and I would also like to take physiotherapist, and because this child will need multidisciplinary approach in order to for the rehabilitation. So we need to involve the nurse and physiotherapist, dietitian, everyone.
Okay. And so in terms of the other professional inputs, you've mentioned the physiotherapist. Any other professional would you like to involve?
Community pediatrician, pediatric neurologist.
Yeah, pediatric. And what do you think the pediatric neurologist would do?
He will look out for the underlying cause, that what is the underlying cause of this, and he will help him in following up, like whether the weakness is going is increasing, or does he need any like he will keep a track on the progress of the lesion in the brain.
Okay, and in terms of the rehabilitation, would you consider any other professionals?
In the rehabilitation, occupational health can also help them in the fine motor skills in order to have a good like a daily life, so he would be able to do his daily life chores, and physiotherapist will help in strengthening the muscles and the gait. They will work out on them, and social worker maybe to support the family they need.
Okay, right. And yeah, so any other discipline involvement, or any other in terms of managing this child? Any other thoughts, like the input from the school or the education?
School and education.
Yeah.
The school nurse. I don't
That's
know.
fine. You would ideally assess the child's higher mental functions, and then we can decide on the education plan for this child.
Yeah.
Yeah. So I think that's it. Yeah. Is there any other thing you would like to add, or do you think of going starting from the examination till the end, and then we can start the discussion? Like
I think I don't know the system here, so whatever comes in my mind, I told.
Sorry, say again.
No, because I'm just saying that we don't know the exact system. How does they do things here? Because we don't get usually such patients, complex patients. So like whatever.
Guys, can I practice one scenario as well of neuro, and then we can have discussion?
Yeah, that's fine.
Yeah.
So,
do you want to discuss and finish this first and then do with me, or do you?
Yeah, I think that would be better, because we may lose the point.
Yeah, please carry on.
So in terms of examination, I think that was fine, but again, you almost nearly missed the I mean, the first part where the patient had come with walking aids, and you had to.
I think I have not verbalized it because I have written it. Maybe like
yeah,
that
I
I
mean,
will see for the.
in actual look, in actual examination, when you see that thing, you will be picking it up. But the reason I'm emphasizing that again and again is that if you know that you need to look for these things, you will only then be able to pick it up, and you will try to put this in your list of positive findings in your summarization. So don't forget these most important bits, because these walking aids and these bootstraps or wheelchair, they may be kept as a side, and if you jump directly on the examination, you are more than likely to miss it. So that was one, just as a reminder. But although you did catch that point, so it's not missing in.
Yeah, I have written it that I will go and see for the neuro like inspection all over. I will see the neurocutaneous stigmata, dysmorphism, hearing aids, vision aids, and walking aids. I have written this thing. But,
No, that's right. I'm not denying that you have written. You've got that in your notes, and you would have in your first 4 minutes of preparation, you will go through this in your mind. But in the actual examination, verbalizing, you probably missed it out in the where you were supposed to pick it up in the starting. So towards the end, I think you mentioned it as a um, um, as a summarization point of you would be doing this and that to tick the boxes, wasn't it?
okay.
Yeah. So try to be. I mean, again, stick to the structure of the examination. That this is what you would be doing first, and in this particular instance, when you are you would be needing to expose the patient. So any lower limb, and you know that the child's age is 14, you know that the child age is beyond 6, 8, or things like that. So
It's 14 months or 14 years?
14 years, 14 years.
Hmm.
So you know that the child is older, so you have to bear in mind the sensitivity. So in your actual exam, you will have to sensitively ask. So I would just need to expose your lower part of the lower part of your legs. Is that all right with you? So you have to seek permission and then expose the patient. Okay. So and otherwise you will be missing. You will be missing what you if you miss that point. If you do not expose the patient, you will be missing the wasting, you will be missing any surgical intervention, scars, or you'll be missing any problems at the back. So, so it is important that you have to expose, even if you are, for example, if it's a boy and you are as a female examiner, you will have to sensitively seek permission to do that. In other instance where it's a male examiner and it's a female girl child around 13, 14 years old, they will have to make a comment that I will have to expose. And if they say that no, it's okay, you can examine without exposing, then that means you are free from it. That means they do not have any sign that you need to pick up on inspection. So but it's important that you mention that part, and then you proceed with the examination, and then uh, you try to describe what you're doing to the child, and then give the instruction. So instead of going and like saying walk from here to here, so can we just do a little bit of walking? So could you please walk from this corner to this corner of the room? And when I asked you what maneuver you would be doing, what I wanted to find out from you was that when you initially made the child walk, they will obviously be walking at their own pace and in a restrictive manner, because he has got a walking aid with him. He is not using that aid, so he will be struggling to walk. So you had to make sure which you did really well in terms of making sure the child doesn't fall. But what I was expecting out of you was to make him walk fast. So when they walk fast, um, the circumduction gait becomes evident. Okay. So so that is one maneuver which you can bring out the gait thing. And when you are assessing the gait, it's whether it's a musculoskeletal examination or a neurological examination, try to ask them to walk normally. Try to walk them ask to walk on the heels and the tiptoes as well, if they are able to do so. Okay. Yeah. And then you proceed on with your checking for tone power, reflexes. So all of these checking for the tone consist of three parts, which is inspection, palpation, and the examination as such. So inspection is you're observing the muscle bulk, which you have rightly picked out. There was a loss of muscle bulk. Yeah, so you've done the inspection part, and then you do the palpation by palpating the muscle bulk, asking the child to lay down and palpate the muscle bulk, do a log roll maneuver to see how the tone is. And in this instance, you would have found that the tone was a bit hypertonia. You have to look at the attitude of the limb when the child is lying down, whether the back of the knee is touching or not, whether the side of the foot is touching or not. And So that is all part of inspection, palpation of the muscle, and then the active movement of the joints. And when you're doing the active movements of the joints, start with explain the child what you're going to do. So I'll just be moving the joints, Joe, and then you start with the slow motion, then go to the fast motion to get the catch, the spastic catch towards the end of the motion. Do you understand that? If you have any questions, if you're not understanding anything, just let me know. Are you able to?
Could you please repeat the last thing which you said? Like the cogwheel rigidity, are you saying?
Not the cogwheel rigidity. Yeah, I mean, here what you're trying to get is the spasticity, the differentiation between spasticity and rigidity when you're doing the passive movement of the limbs. So when you are moving it fast and you appreciate no change of the tone, and it's on the higher side, the tone is on the higher side, then that is more of a rigidity. But there are very few instances where you will be getting this. It's mainly seen in adults. In the children, you'll be getting upper motor neuron lesion, which will be a which will be a hypertonia or spastic tone. The rigidity is a problem of the basal ganglia. Okay. And that is more commonly seen in adults. In young children, very rarely you will see those ones with post connectors history, but it's challenging. It's more than likely you would not be getting that. Okay, so you have assessed the tone, because the examiner will and when you're moving the limbs, try to hold your other hand at the bulk of muscle bulk, to feel for the tone in that particular muscle. Okay, so this will demonstrate that you know what you're looking for and you know how to assess the tone. That is the actual right technique. Most of the candidates, what mistake they do is they hold the joint and then they're moving the limbs. For example, they will hold the knee joint and then they are moving the legs by uh, moving, I mean, by the flexion and the extension motion. But what you need to do is hold the assess for the tone at the quadriceps. When you are extending the knee, you are checking for the tone of the quadriceps. When you are flexing, you are checking the tone at the quadriceps. Try to hold feel for the tone in the quadriceps, and also place your hand. Yeah, put your hands on the muscles to be able to. Yeah, to be able to do that. And then we've described the tone. Yeah, so when you're assessing the power, you could do it either the child sitting or the child lying down. So you just explain, and this is where you need to actually practice by on your actual these patients, by asking them, by giving them the instruction, how would you be checking the hip flexion, how you would be checking the hip extension. So you can give them instructions like lift your leg, as you did, lift your leg straight up and don't let me push it down, and then you put your hands above the knee and then try to first step, you ask them to raise their leg, and then you are asking them to put it down, but you are applying resistance, and then in the second instance you are now applying the resistance on top. So in this way you have checked the hip flexion and extension. And then you do the same with the knee flexion, bending your knee, and then you apply resistance in the front, and then you apply resistance at the back. Then you have done the knee extension, the power of the knee flexion and knee extension. And similarly with the you go down to the foot. So you're doing it in a smooth, systematic manner. You're going from hip, knee, and ankle, and this will be much quicker. And ankle again, plantar flexion, dorsiflexion. Okay. Are you able to get what I'm saying? I have a PDF of this examination. I'll share that with you guys.
Okay, yeah, no, we are getting.
Yeah. So, and then you proceed on, do the normal leg first and do the affected leg after that.
Okay.
So, and then you move on to the checking of the deep tendon reflexes, the patellar and the Achilles tendon, which I assume you should know the technique. You would be knowing how the technique is.
I have one question. If God forbid we were not able to elicit the tendon reflex in exam, then what will happen?
Look, you have to know the basics. Like, you have got hypertonia for, so you would be expecting a exaggerated reflex. So and the examiner will be looking your technique. How do you check for the deep tendon reflexes? For example, in the patellar tendon, you would place your hand beneath the limb, beneath the knee, and let the knee area, the shin area, the leg area be free without any support, without any other thing, and you would be exposing the quadriceps. Again, if the quadriceps are covered, that means you will probably fail on your examination technique. You will expose the quadriceps and give a gentle tap. If you do not get, do a what do you call that maneuver where you have to distract the patient? Yeah.
In which you will to clench the clench feet and also make like also interlock your hands and say 1, 2, and 3.
Yes, you can use that as a distraction maneuver and then do it again. So even if you do this and you have actually tapped the patellar tendon, you should get a reflex. Even if you are not able to get it, you know that in a spastic tone, you expect you expect an exaggerated reflex. You can mention that to the examiner that I although I was not able to elicit the tone during my examination, but I would expect exaggerated reflex on reassessing the patient later on.
Okay.
There's no harm in saying that. And if you see a lower motor neuron lesion, if it's a floppy or a hypotonic limb, you would not be getting any reflexes. But if you do not comment that you have got any reflex.
Okay.
Only comment if you have got it, because that is called as making up clinical signs, and which is a negative mark in your anchor statement.
Okay.
Okay, so be honest with your this thing. After your reflexes, you move on to the cerebellar assessment. So you can do the heel shin test, which you have done rightly. In this instance, you will get a asymmetrical heel shin test on the affected side, and the child may not be able to completely do it as well. So and then you complete your examination. If you've got time, you proceed on with your sensation, but it's not exactly, they don't expect it to do the sensation. There's actually a separate station for sensation, but a good way to remember the sensation, if you get time, if you do it swiftly, in a swift manner, you'll be getting extra marks as well. I mean, you'll get a good impression upon the examiner. So you can start with the groin, which is L1. Then you go to the thighs, L2. You go to the knee area, which is L3. Then you go to the as you go below on the lateral aspect, it's L4
on the medial side.
Yeah. Then L5 on the lateral aspect of the leg, L4 on the medial aspect, and then
S1 on the medial
S1
and
the sole, S2 the posterior aspects of the leg and the thigh. Okay, so if you proceed from L1 to L5 and then S1 S2, that should cover your dermatomes. And do it one leg to normal, abnormal, normal, abnormal. Do it together. Like if you're doing on the for in this instance there was the right leg which was abnormal, do it on the left leg first, then do the right leg, L1 L1, then do L2 L2, L3 L3, and go proceed like this way. Okay, don't do one at a time full and then do the other one, because you need the child to perceive what is normal and what is abnormal. Do you understand that?
Yeah.
And that should complete your complete neurological assessment. Okay, and then when you come to summarizing, I've examined. So again, we have missed the initial part of plotting the child, how the child appears, well grown, undergrown. The child was, because it's a chronic case, malnutrition, wasting. The child was undergrown, so he was plotting less than 25th centile and less than the second centile. So that is something which you try to bring it again and again in your examination. Okay, don't forget it. So I've examined so and so who is uh, who appears to be undergrown or poorly nourished for his age, but I would like to plot him on an appropriate growth, height, and weight centile chart, and um, he's come with a walking aid, and on examination of a neurological examination of his lower limb, then you proceed on with your positive findings from the from in the sequence of what you've got. Then on the assessment of his gait, he was there was circumduction hemiplegic gait, and there was wasting of his muscles suggesting of a chronic illness. And then on the assessment of and he has reduced power, reduced tone, hypertonia and reduced power, and then which you list your examination findings, all the positive findings in that sequence, and then you give your differential diagnosis that this suggests of a upper motor neuron lesion, hemiplegia. This suggests of hemiplegia of the involving the right side of the lower limb and upper motor neuron lesion because of this spasticity. And then they will ask you the causes and what are the common causes, which you have listed really thoroughly. So yeah, just try to be systematic in your summarizing. Okay. And yeah, any questions so far?
No. And I would like to ask regarding the Viva. Will you also discuss that, because I was a bit lost in that?
Yeah. So we'll discuss that after this. But with the examination technique, any problems at all? And what do you like? What was your take home point? What do you think you'd be doing better improvising in your next? You've done well in this exam. You've done well in the assessment. You've picked up your science, but just a tiny bit of modifications, which
I forgot to mention about the. I would like to plot the height and weight on the centile chart, and I should have seen the uh, overall nutritional status of that child as well. Uh, as you already told that I should have mentioned about the walking aid, like, and and other than
and
that, sensory system, I would work on the sensory system, and like, because this is the thing which we were getting. I was getting messed up, because if we are looking in the past test videos as well, they're also not clarifying. Like, they're just giving this. They have just given the conditions, and on that conditions they are doing the examination. So I was like concerned, like, if the command is lower limb examination, so are we supposed to do the upper limb as well, like cranial nerves as well, or not? Because what we
no,
used to do is,
adapt to this format and try
yeah.
to stick to that in this one. And then towards the end you would mention that I would like to complete my examination by looking at the back for any scars or scoliosis, and do a complete neurological examination including the upper limb and the cranial nerve assessment.
Higher mental function we won't assess, right?
No, it's not. It's not something that is routine part of the a neurological assessment here in the UK.
Okay.
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 So.
And what about the causes? Like the causes, I was so scattered because in my mind initially the CP child was coming like with a hemiplegia, but then I thought this is a 14 years old, so this could be a sickle cell, SLE, vasculitis, moya, protein C, protein S deficit. Like there are a lot of causes. So if this sort of scenario comes, so how would we categorize? So this the causes could be infectious, any like thromboembolic phenomena, vascular causes. Like we should explain it like this, or
Yeah, you can list your causes like this. Like you can
vascular
group it
infection.
as the congenital cause. For example, I wanted to ask you whether what do you think it's chronic or acute, which you identified after a prompt that it is a chronic because of the wasting, and the child was well alert and otherwise active, so he's not in acute pain or something. So you can list congenital and acquired. Congenital are birth traumas and perinatal stroke and any other antenatal insult at all. An acquired cause can be hemorrhage, thrombosis,
Okay.
or a static brain injury like cerebral palsy, like hypoxia.
Trauma.
Yeah, and then the thrombosis, which you were listing, those are the hypercoagulable state, sickle cell, thalassemia, dehydration, nephrotic protein CS deficiency, and cyanotic heart disease. So those are
Yeah,
thrombotic.
cyanotic I forgot.
Yeah, and then hemophilia as well. And then you have got
Okay.
infectious causes, torch, meningitis, encephalitis, and then vascular lesions, like I mean moya, which you have mentioned. But try to, if you have mentioned that, you should also know a bit of background as well. If the examiner picks on that, then you might be in a soup. So do you know what is moya?
Yeah, I know
Moya
about them.
transient ischemic attack. It's better not to mention in this case, I believe.
Yeah, so it is
We can
characterized by
say
recurrent episodes of.
recurrent episodes of stroke because the vessel walls are weak and they
Yeah,
form aneurysm.
it's abnormality in the vasculature, and
Vascular
what is
wall
the
and
what
gun
is the characteristic?
puff of. Yeah, this, on MRA we see puff of smoke.
Yeah. So if you know these 2 points, that's good.
Yes.
You'll be getting good marks there.
We
But
do and arterectomy and I have
embolectomy,
read.
yeah. So it's very unlikely the discussion will go into this part. But if you list broad causes like congenital and
Mm.
acquired you have hemorrhage and thrombosis, hypercoagulable states, hyperviscosity, and then infectious and vascular lesions. If you list it in this manner, and then you've got tumors like glioma and then trauma as well.
Okay.
Okay, I think I remember I used to have a mnemonic which was for all the causes. Oh, yeah,
With
for all. So it was an important mnemonic that kind of fit into all the causes of anything in the medical field, which was called
okay.
as vindicate, like vascular, infectious, metabolic, uh, and I don't exactly remember, but I'll try to give you guys that.
Vindicate. V
Yeah,
I Vim or Vim
vindicate, VINDICATE.
I
So yeah, try to fit in whatever you can get in
vascular
that letter.
infectious metabolic D for dehydration.
Yeah, you can put that.
I
Doesn't matter. Yeah, it is valid.
and then C for I don't congenital A
Yeah.
for trauma. The last
Yeah,
one could be
trauma. Yeah, trauma is also trauma was also there. I don't remember what was E. Anyways, I'll try to bring that up.
okay.
But this is
Thank you.
this is a broad heading for a lot of causes, for a lot of things. So
Thank you. At least you are appreciating that we know something.
yeah, I hope that's useful. It was quite helpful for me. In my theory exams as well, I used to put the same thing everywhere again and again, and that was working. So and then in terms of investigation, again you would do um, um, you would do the basic ones and then the specific ones. Basic ones is the FBC, use and ease, to check for nutritional assessment, electrolytes, because if the child is on any kind of medications. So and then the specific ones will be neuroimaging, and you would like to also consider metabolic workup. So you do chromosomal analysis, metabolic screening.
Yeah, because I think homocystinuria can also cause. In homocystinuria, we also
Yeah.
have, na?
Yeah. That's also a hypercoagulable state.
Hypercoagulability.
Yeah, so you could do a urine assessment for the cystine crystals in there, and it would include the metabolic in the metabolic workup. So you can do metabolic screen, and then you could just add on things like torch screen and the eye and ENT assessment as well.
Okay, but torch screen we will do at this age as well.
No, you can tailor these lists depending upon the age of the child. So
Yeah,
I'm
because
giving you I'm giving you a general broad list of investigations that you can do in case of any neurological problem or any if the child is young.
Okay.
Because torch can also cause meningitis, and you can have hemiplegia or CP as well in a younger child. In this particular 14-year-old child, you would do the basic test to assess for nutrition. You would do a bone profile. You would do a neuroimaging if that's not been done already, and you would do metabolic screening and chromosomal analysis if based on your initial results, and then involving and management is you would refer the child, discuss this child with your consultant, refer the child to pediatric neurologist who would look into the exact etiology, as you mentioned. If the child needs any muscle relaxant, if it's a CP child with a lot of high spasticity and contractures, so they can give any kind of muscle relaxants, and they can also liaise for the contracture release. So the pediatric neurologist will be taking that in responsibility, and then physiotherapist, occupational therapist to aid in the mobility and the daily functioning of the child. Communication, you will assess the communication. Then obviously the social worker you mentioned, and dietitians, and the broad list of just prepare a broad list of these different specialities, and you can put everyone in by doing this. If it is a young child, you would also like to involve the neurosurgeons as well, if there's an element of hydrocephalus. Okay. But broadly, you have listed out almost everyone, and I had to prompt you for occupational therapist because which is quite important in this instance.
Hello?
Yeah, I can hear you now. Yeah, is that it?
I had a question that can we offer chaperone at this age group or not?
Yeah, that's a good question. You can ask for a chaperone, but in your it was more suitable when there was a non-patient based examination where you were describing your examination. So we had to mention for a chaperone, but here you will have the examiner in front of you, so that can act as a chaperone in themselves. So you don't need any additional person on top of that, but you can check with the child with the child. Would you like anyone else to be here with you? That's appropriate to check with the child. There's no problem.
Okay, thank you.
Okay. Anyone else? Any question at all so far in terms of examination and management?
Dr. Reis, you were saying in the last, like, what else? What do you want me to say?
I think you had not mentioned the occupational therapist, probably.
I have mentioned. I think I have not mentioned the dietitian, and I didn't say about the neurologist will go for like will help in the muscle will give the muscle relaxants, and I have not mentioned these things.
Yeah, so it could be just those things, nothing more other specific, but probably, yeah, I was mainly checking for occupational therapist intervention, and yeah, and the education thing was, um, you would check if there was education plan in place for the child, and you have to just ensure with the examiner that you are aware of that these requirements are present, because he'll be attending special school, and
Okay.
if there is no plan in place, you would like to check that.
Okay. Okay. Thank you. So if
Okay.
like what would you rate 6 weeks before exam? Would be able to like improve it after the 6 weeks or?
Yeah,
Too
sure.
much?
I mean, the improvement required in your today's performance is quite minor. Like,
Mhm.
it's not major thing that you have to work on.
Yeah.
It's minor, those small things, but uh, you have to work on those things so that the mistakes you made here were those mistakes which you knew already, and despite knowing,
Yeah.
you missed it. You
Yeah.
you had written down everything, but you
Yeah.
missed it in your um, during presentation, because there was an element of a bit of anxiousness, and it will be much higher in your actual exam, so you are bound to miss a lot of things unless and until you are practicing it really well.
Okay. And what else I can do to make my summary very sleek and uh but I was saying like should we just prepare the summaries of every case and just like trying to
Yeah,
learn point.
I had specifically practiced summarizing
Yeah,
before my
because
exam.
what I think is my weak point is like when I have lots of knowledge in the end, like in this case, like I know this is a 14 years old boy who is having a hemiplegic gait, the and the clinical signs are consistent with the upper motor neuron lesion. So
Hmm.
like how would I explain all those in just 3-4 lines rather
Yeah,
than taking
so
lots
the
of
the
sentences?
yeah though so the art of summarizing is basically, you have an opening statement which will include the general mood and the general behavior of the patient, that I've seen so and so 14-year-old or 4-year-old, uh,
Well, or
yeah,
look below average.
who's alert and active, and who appears well for his age, well grown or
Okay.
undergrown for his age, and then
Okay.
and this
No
is the opening.
dysmorphic features and no cutaneous neurocutaneous stigmata.
Don't
Should
mention
be.
negative things. If he has a
Acha.
dysmorphic feature, mention that. If he does not have, don't
Acha.
mention without
Oh,
this, without this. That's what
okay.
I'm telling. The art of summarizing is to list out the positive
Mhm.
findings, and avoid
Okay.
listing negative findings unless and until it's very important for that instance.
Okay.
Okay, so you've made an opening statement, and then so today I've assessed his neurology, and or I've assessed his development, or I've assessed his cardiovascular system,
Mhm.
where he appears to be. Then you list out uh, your positive findings of your examination. So on examination of his gait, he had a circumduction gait suggestive of hemiplegia, and he had a wasting of the right side of the muscle, and then he had the low decreased reduced power in that limb, and brisk reflexes on and so in so these findings are suggestive of a lower of an upper motor neuron lesion, and most likely hemiplegia. But I would like to complete my
Okay.
examination by doing a full neurological examination, including the neurology of the upper limb and the cranial nerve assessment, and also looking at the back for any possible scoliosis or scars.
Okay. Okay.
Okay, so
Okay. And the blood
opening
pressure
state,
as well.
yeah, you will do a full set of obs, blood pressure, and these are common things you will be mentioning in all your examination. So if it
Okay.
was a cardiovascular, you would say opening statement, so and so with who appears well, and if they have features of dysmorphism, you mentioned that he has got features suggestive of trisomy 21. And what else? Yeah, and then you list your findings, positive findings, and then you go on with by giving a broad differential diagnosis. For example, if you've got aortic stenosis, say you can say he's got a left outlet obstructive problem with the heart, most likely to be an aortic stenosis. So if you give a broad one and then you narrow it down, that gives a very good impression to the examiner. But as long as you are able to, if you miss, for example, the specific diagnosis, the narrow one, the specific diagnosis, like if you get that incorrect, but you have given a broad one which is right, so that will save you those extra marks, that you will get those extra marks of listing a diagnosis. Okay.
So, for example, in this case, do we need the exact diagnosis from us, or
no? Your diagnosis, you do not know the etiology. What you know is that it is your findings are consistent with a hemiplegia, but you have not examined the upper limb to say it is a hemiplegia. So you've got is assessment of lower limb, and you've got a monoplegia of one of the limb. So you can say that because you have recognized that there was flexion of the arm, so you can safely say it's hemiplegia. But you will need a full examination assessment of the upper limb as well. So yeah. But if you mention, so whatever you mention your list of differential diagnosis, if you have got more than one, try to mention the most common and then go to the least common.
okay?
So I would say practice. Try to summarize for each station, each system, and keep these things in mind. Avoid giving negative statements right at the front. No dysmorphism, no. So in cardiovascular, you would say that there are no features of any infective endocarditis or no signs. No, he doesn't seem to be in failure. Those are important negative findings. Okay.
Okay, there is no signs of cardiac failure in the form of basal crepitations, edema, or raised JVP. Do we need to say like this, or just
No,
there
no,
are
no,
no
no,
signs?
no. You don't need to mention those things.
Don't mention the negative
There are
things.
no signs of cardiac failure and no stigmata of infective endocarditis.
Yeah, that's enough. That is more than enough. So this
And
is
even in the cardiovascular, like the past test videos, they are very haphazard. So I would like if you could take our session on one of the cardio, one on respiratory you have already taken, and on musculoskeletal as well.
yeah. I was planning to take musculoskeletal and examination of the neck, and yeah, we'll complete this neurology and then we'll go to the musculoskeletal.
Okay.
So yeah, we will do a quick one for the next one.
Okay.
So you've got the same scenario, but here you are asked to do a complete assessment of the cerebellar function.
Cerebellar.
Yeah.
Okay. What's the age? Same?
Same boy, but not the same findings. Okay. So same age, same boy, and he has come. You can call him Joe again, and you are asked to do the cerebellar assessment of this child.
Okay. Give me 2 minutes, please.
Yeah, 1 second. Let me.
And Dr. Reis, when we are like.
Yeah, so I can start now.
Yeah.
Okay. So shall we start? Are you keeping the time?
Yeah. Let me just set the timer again.
Yeah.
6 minutes. Yeah. Go on. Start.
Okay, so I'll first of all wash my hands after coming inside and introduce myself. Hello, this is Myra, one of the candidates. How are you, Joe?
Yeah, I'm good, thank you. How are you?
I'm good, thank you. So today I'm going to examine you. So quickly, we'll just see how you walk and how are just things going on. Is that okay with you? And if you feel any soreness or pain, you can let me know.
Yeah, sure, no problem. Thank you.
Okay, that's perfect. So first of all, I'll just inspect and go around him and look for any walking aid or any visual aid, hearing aids, or any other aids like he's using any medications around or any nutritional support. Then I'll
No,
watch if
yeah.
he's a well-looking or a non-well-looking child
Yeah, so he's a
and
well-looking
his
child and there are no medical equipments or aids around him.
well and no medical. Then I'll ask him if he's able to walk.
Yeah,
So are you
so
able to walk, Joe?
so he reports that he is able to walk but with a bit of difficulty, but he can walk.
Perfect. Perfect. Okay, so what we can do, Joe, is I will just try to hold you. In the meanwhile, can you just walk from this point towards the door for me?
Yeah. So
Oh,
yeah, as you can see, so when he walks, he's a bit wobbly at his feet,
okay,
and
both of you wobbly. Okay,
yeah, so he's a bit um, struggling to get the balance, but he's able to make from point A to point B.
point A to point B. Okay,
Yeah,
so can I
and
ask him? Can
there's a
I ask
broad
you,
base.
Joe, to
There's a broad based gate.
broad-based gate? Okay, sure. Can I ask you to just walk on a line for me from heel to toe? Joe, can you do that for me?
No, so he's struggling to do that.
Struggling to do that. Okay, so Joe, can you close your eyes?
Yeah.
And I'll see if he's like wobbly. He's still the same, or he falls down. So is he still same
So
after
he
closing his eyes?
so with the what when you ask him to close his eyes, you can see that he's got a tendency to fall towards one side.
Okay, he has got a tendency to fall on one side. Okay, I'll just hold him and then I'll ask him to open. Joe, you can open your eyes and
Yeah.
you sit for me, and then I will make him sit, and then I will see if he's doing fine. I'll ask him, can you copy this for me? I will show him how to do a finger nose test. I'll put my finger to my nose and then to my hand and ask him to repeat the same for me. Put one finger on the nose, on his nose, and then on my finger, and as fast as he can. So can you do that?
Yeah, so you can note that when he's trying to do that, there's a bit of tremor in his
Oh,
hands, and
okay.
there's slight um, uh, in coordination when he's bringing to his nose, and he tends to pass point and um,
Okay.
yeah.
Okay. So I am show him to do the dystidokinesia test. I will show him to do it. So let's play something like this. Joe, are you happy to do that for me?
Yeah, so
So
he does it.
is he able to do that?
He manages to do it slowly, but he's able to do
Okay.
that. Yeah,
Okay. Okay.
he's
Perfect.
not able to do it in a rapid sequence.
Okay. So at this point, I will ask him to focus on my finger and look for the nystagmus. Does he have any nystagmus?
Yeah, so he does have a nystagmus, uh, which is
Okay.
which is mainly at the extreme end of the movement of the eye on the lateral side.
Okay. Okay. On the lateral side, both of them.
Yeah,
Okay. At this point, I will ask him to okay, so because he's sitting at the moment, so I'll just ask him to lay over, just let his legs relax, and I'll look for the pendular knee jerk reflex. So I'll just hold his knees from the downside, and I'll put the hammer on the knees and see how is the pendular knee jerk reflex present or not. So is it there?
yeah. So you can so there is absent pendular knee reflex.
Absent. Okay,
Yeah,
perfect. At this point, I will ask him to lie down for me, and I will
yeah,
show him to do a heel to shin test. I mean, I will ask him to can you raise your leg for me, and then just put it all the way from your shin to your heel. Can you do this for me? And I'll ask him to repeat it with the either of the leg.
Yeah, so he's not able to do that. He's struggling to bring it down in a straight line, and he tends to um, um, deviate his legs away.
Okay. Okay. So at this point, I would like to have a look on his spine as well. I mean, yes, I would want to do it ideally when I asked him to walk, and I would look for any spine deformity at that point, like spina bifida or any lordosis or scoliosis. I would like to see for that, or any scar on the neck I would like to see, and I mean any post surgical scar I would see for, and I would like to see if he's, as I told, is he having any visual or hearing aid at the moment?
No, so there's no. He's wearing glasses, but he's not having any hearing aid, and
Okay,
there's no. His spine and his back is normal.
okay, okay. So at this point, I would like to start his lower motor,
Sorry,
lower leg
sorry,
examination.
sorry. In the examination of his back, he's got kyphoscoliosis. I'm sorry about that. He's got kyphoscoliosis.
Okay, and any scar?
No scars, no scars.
Okay, okay. I would like to quickly palpate his bladder. And is there any bladder palpable, or is he wearing any pampers at the moment?
No, so you can't feel any bladders, and he's not wearing any diapers at the moment.
Okay, okay.
So
And
the
now
yeah
I would like
the
to, because I have time, so I would like to start his examination of lower limbs, motor
um
examination of the lower limb.
no, so the time is up. But you're not expected to do a separate examination of the lower limb as such, like testing for tone power for the lower limb. You have done you have completed your task of cerebellar examination, and that includes head to toe assessment. And when you find positive signs, so you can that's it. That should be enough. Don't worry about that. Don't worry about going into um, specific assessment of the lower or the upper limb.
Okay, that's fine. Yeah.
Yeah, so when you are given the task of cerebellar assessment, so you do from head to toe, which is head for any head titubations or head ataxia, what you can say, and eyes. You come to the eyes for nystagmus. Then you come to the upper limb, where you could do a rebound test, and you could do a tremor. Ask them to extend their hands out
Then,
and
yeah.
keep a place of sheet of paper and see for any possible tremors. You observe the trend for any ataxia, and then you do the lower limb with gait and the sorry upper limb. Just going back to upper limb again, the finger nose test and the dysdiadochokinesia, and then you come to the lower limb where you do the gait and the heel sheen test, and that should be enough. That should cover. You should get good enough signs, and you have also done the
Okay.
reflexes, which is also part of the cerebellar assessment, so that should be fine.
Yeah. Okay. Okay. That's fine.
So so how would you close? Well, like what would be your closing remark? What would you like to do based on your
Okay.
findings?
Yeah.
What
So
else? So the examiner asks you, what else would you like to examine?
at this point, I would like to examine the cranial nerve, especially the eighth cranial nerve, uh, eighth cranial nerve, and assessment for any palsies. And apart from that, I would like to check for the higher mental functions and blood pressure,
Okay.
as well
So
as the full neurological examination.
so what makes you? What are your thoughts? What is your impression? And like, yeah, can you summarize the case for me?
Okay, so I have examined cerebellar signs or cerebellar examination. I've done a cerebellar examination of Joe, who's a 14-year-old boy who appears to be well for his age. And on the gait assessment, he was kind of wobbly and having broad-based gait, and which could be a sign of truncal ataxia. And he has cerebellar signs positive in in form of a tremor while doing the pass point and in coordination while doing the dysdiadokinesia and heat-to-shin test. He also has nystagmus and absent pendular jerk. So, and has a kyphoscoliosis significant. So I could appreciate all these signs. So I feel that there could be an acute or a chronic cause of cerebellar ataxia. He also has a positive Romberg sign, so this could be sensory as well as motor cerebellar ataxia.
Okay. So, yeah, what can you talk a bit more about the Romberg sign and what is sensory and motor difference between sensory and motor ataxia?
Okay, so in Romberg sign, if in the sensory the child is having ataxia, and if you ask him to close his eyes, and if he falls on one of the side, then it is positive sensory. I mean, there is some sensory involvement as well.
And where do you think is the involvement, the site or the lesion? Um,
This could be
what track?
medulla. Yeah, this could be, I think, medulla oblongata or cerebellum and cerebellum basically at this point.
All right. So, is there any other test you would like to do to differentiate between? So how would you know if it is a involvement of the cerebellum or the nerves or the muscles? Is there any test you would like to do for that? Do you know of any test that can be done that can differentiate whether it's a problem of the cerebellum, or cerebellum and the nerves, or the muscle?
I think for the nerves, I can also do for like it's to rule out the dorsal column.
Yeah, you're just
So proprioception and vibration.
no. My question was, how would you know whether it's a lesion at the the brain and the nerves essentially, or is it the problem of the muscles? Well, what do you how would you know if it's a muscle weakness?
I would watch for wasting of the muscles or waddling gait, or there is any Gawar sign positive in this one.
Yeah, that's good. So you would be looking for Gaba signs there.
Yeah.
So
Waddling
based on
gait
your,
and then
based
winging
on
of
your
the scapula.
so what were based on your positive examination findings, what do you think is going on with the child?
This could be cerebellar ataxia, an acute or a chronic one. I would like to rule out on the basis of history and exam history and
What makes you say that it's a cerebellar ataxia?
but because of the presence of all the cerebellar signs, like as I said, the incoordination, nystagmus, and absent pendular jerk.
Um, but you
Okay.
performed one test that can differentiate whether it's a cerebellar lesion or it's a lesion of the posterior column. Do you know which test is that?
Yeah, Romberg.
Yeah, so it's more of a sensory
Hmm.
problem, isn't it?
Yeah.
Yeah. So, do you have any diagnosis? Do you know of any condition that can involve the sensory tracts to give you ataxia? Because the
Yeah,
nystagmus.
it's post varicella or
Okay.
post varicella or what do we call it? Vitamin B12 deficiency.
Okay. But do you have any signs suggestive in your examination to suggest for a vitamin B12 deficiency?
I no, I would like to have a complete examination for that one. But
Okay,
it
no
is
problem.
purely sensory probably, yeah.
No problem. So, just coming to the causes of ataxia, uh, what are the causes of ataxia?
Okay, so there could be acute like trauma and post-infectious like varicella, and apart from that, there could be some tumor like medulloblastoma,
Yeah.
and yeah, so it
What
could
are the
be
common
ischemia,
causes of
stroke, hemorrhage.
what are the most common causes of ataxia in a child of this age?
It's this age. This could be post-infection and ataxia telangiectasia or a rare condition like Friedreich ataxia. But for that, I need to rule out for other associated findings as well.
Okay, fine. So what investigations, how will you manage this case?
Yeah, for this case, I would like to go for routine bloods like full blood count, and I need to find out first on the basis of history if it's an acute problem or a chronic problem, and then I would want to go for routine bloods to rule out any acute infection or any acute bleeding or stroke. For that, I need to do the clotting screen and platelet count, and apart from that, I need to do a CT scan. Or if it's a chronic problem going on, maybe MRI brain. And apart from that, I would like to involve the multidisciplinary team, having a physiotherapist and occupational therapist, and a pediatric neurologist on board to view for any current. I mean,
So
to review
suppose just coming back to management part, you've got a 14-year-old child who's coming with an acute onset of ataxia. Is there any other thing you would like to think of? And would you like to do any particular investigations or test for that?
I can just think of blood test like platelet and clotting screen and neuroimaging. And
And so what do you expect in terms of blood test of clotting screen and platelets and neuroimaging to what are you thinking of?
I mean, to rule out any bleeding or hemorrhage, I need to do these blood tests and
So you
rule
have
out
this
any
child. So you have
tumor.
this child in front of you, and he is well child. He's cooperative. Do you think he's having a hemorrhage?
No.
Okay. Fine. So that's the end of discussion timing. Okay, no problem. Yeah. Can you think of any acute cause of ataxia in a teenager?
Brain tumor, medulloblastoma.
The more common cause. It's okay. Fine. We'll
Post
come back to the discussion.
Post varicella. We have seen like children coming
varicella,
from with post varicella. I mean,
Yeah, that's
very relevant.
fine. Post varicella is quite common cause, which I completely agree. So you will need to look for acute history of infection, but you're here in the UK, and here one of the most common cause of acute ataxia, especially a teenager, is substance abuse.
अल्लाह अकबर, वो तो हमारे दिमाग में ही नहीं था कभी.
Really, Dr. Raisa, I couldn't think of it.
We cannot even imagine in any part of our brain.
Yeah, if you work in peds, one of the first things you would do, a child coming in with ataxia, is a urine toxicology screen, and that's what the examiner would expect, and that's what you would need to list out: urine tox screen and blood alcohol levels.
Yeah, blood alcohol levels. You're right, and urine for tox. Okay.
Okay, so let's go back. Let's go back to the starting of the discussion and your findings and everything. Okay, how do you think? It was a bit difficult, challenging one. I understand. But yeah, what were your thoughts? And Maham, you can also give your inputs if you have any questions.
But this was a really nice one because we can never imagine substance abuse in that.
That is, as I said, it's quite common, the most common cause and that's why I kept on stressing teenagers.
Yeah, we have seen so many. I mean, I haven't encountered, but have heard about such histories in handover. Yeah.
Myra presented like she did it very well, but she was a bit, I think, anxious during the discussion. But overall, I think she performed really well.
Yeah, she was brilliant in her assessment, in her examination, and everything. But in terms of clinical reasoning domain, when you come to you've rightly identified, you've done the physical examination in a well structured manner. You've addressed all the points. You have picked up all the clinical signs. That was absolutely fantastic. But there's a domain called clinical reasoning as well.
Yeah, I haven't read this topic for like a long time. That's why I believe my knowledge needs to be refined. That's what I
Yeah.
keep on saying, Aisha, that I need to read book than, practicing, because
Rather than reading, discuss.
I mean, yeah.
Yeah. So when I was asking you where you will see positive Rombergs, negative Rombergs, and what does it signify? So that is where the clinical reasoning comes in, and that's a very important domain in all the clinical stations. So you have to be, so if the examiner sees that you know the science, you know the examination, you've identified it correctly, but you're not able to piece the information and link the information together, that doesn't give a very good impression, although you've done really well. But yeah, just you were not prepared for this station, but obviously you will be preparing it later on. But this is where uh, candidates will lose mark, because when you lose mark in clinical reasoning, you will lose mark in management planning, you will lose mark in the other domains as well. So in an 8 mark station, you can easily lose 50% of marks there.
So here, if I say that acute or chronic, on the basis of history and history, I will decide, and then I would want to treat this child. So would they just give me marks on the basis of the specific diagnosis, which in this case you believe that it was substance abuse?
No, this case was not substance abuse. So I'm just coming to the diagnosis. So when you had identified a positive Romberg sign, which suggests a problem in the sensory ataxia, which you rightly said after prompting later on, but you in your discussion, in your summarization, you have mentioned that the positive sign is related to cerebellar lesion, high, I mean, at the cerebellum, which is incorrect. A positive Romberg sign is in the lower down, in the posterior column tract,
Yeah.
in the area of position and vibration tract. It's not in the cerebellum as per. You will
So
get
all
all the
this
signs.
nystagmus and everything was contributed to the
The
to do
nystagmus ataxia can be present
in the
uh, in
dorsal column tract signs like disease as well.
yeah. You can get
Okay.
that in both the cerebellar lesions and the posterior
Okay.
column lesions. And the
Okay.
way to differentiate between the first point in any ataxia examination is to differentiate whether it's a higher cerebellar lesion or a posterior column lesion is the Romberg's test. And if you get a positive Romberg's sign, then it is very likely that the child is having Friedreich's ataxia.
If the child is what?
Frederick ataxia is right.
Friedreich's ataxia. And
Yeah,
and
it
yeah,
has
don't
combined
and
signs.
don't be surprised that it's a rare case and you will not be getting. In our countries, we get more of infectious post varicella, but here you do get a lot of Friedreich's ataxia, and
So this
especially
was
in exam
ataxia because it has positive signs of.
Rombergs. It has positive Rombergs, and they have stock patients ready, with them. These examiners, they just they come on every exam season. They are paid and they come in the station, and a lot of candidates they fail the candidates and they just go.
Dr. Rai, so that's why the pendular reflex was absent as well, because it is
Yeah,
absent in the sensory efferent
yeah, and pendular reflex. And to be honest, in actual, even in a cerebral lesion, it is absent in it is present in a very severe, in a very rapidly or end of the spectrum disease. So the child has to be really unwell to be able to find this reflex.
Yeah, I mean, we know what to do, what to expect in a Frederick's ataxia, but we haven't seen ever in our life. A and B, in Pakistan, we used to always see just post varicella, always. So we knew it like we will get all the cerebellar signs in this case, and then the discussion will go that way. So it's just that.
Yeah. So you got a bit biased based on that. But coming back to the basic concept, when you've correctly identified a positive rhombus and then you go on to say it's a cerebellar lesion, that is a very contradictory and conflicting clinical reasoning. For example, if I relate to you in a cardiovascular station, so if you have identified cyanosis in the child and you list your diagnosis as a VSD, as an acyanotic, so you understand the contradiction there. Are you able to follow me? Hello?
Yeah, we are listening.
Yeah. So it is as big as a contradiction in the neurological assessment. So if you have identified a positive rhombus, it is you a posterior column defect. It is not a cerebellar defect. Okay, and that is one of the first things that we need to ascertain in the cerebellar examination. And then um, I was prompting you, and I was asking you, how would you differentiate whether it's a nerve or the cerebellar lesion or the nerve lesion, or is it a muscular lesion? So that the examination or the sign you would able to do that is the Gower sign. Okay, so when you ask the child, when you see an abnormal gait, ask the child to do a Gower sign. Ask them to sit down and ask them to get up. That will so what you have eliminated, that when you've seen abnormal gait, ask them to do Gower sign. You have eliminated muscular causes. You have eliminated all the DMDs and muscular dystrophy and everything. You know that now it's either a cerebellar or a posterior column defect. You do a rhombus test. You have now narrowed it down to a posterior column defect, and there are very few cases where you will get posterior column defect. In UK, you will not be getting B12 deficiency. It's almost unimaginable to get that. You will get rare cases like Holt-Oram syndrome. You'll get rare cases like Friedreich's ataxia. You will not be getting B12 deficiency here. So
And A beta lipoproteinemia and like conditions also. But उसमें भी वो होता है ना B12 वो मतलब yeah that is also having
yeah, that is very rare to get here, because they are nutritionally, even if they have that B12 receptor defect or rare defect of absorption and all those things, they are managed. They are well managed. They can't mismanage a patient.
But there was also a clue in this, like if you have taken this case from me, I think I would have also missed. There was a clue as well, this scoliosis as well.
Kyphoscoliosis, yeah.
Kyphoscoliosis, so
yeah.
rhombus present, absent reflexes. I think now we will be able to remember this.
And then I will examine the CVS as well.
Yeah, you will do a hepato. You the other system, when I was asking what else you would like to do in completion.
Blood sugar levels.
Yes, you will do a hepatosplenomegaly examination, abdominal for organomegaly. You will do a cardiovascular. You will do. I mean, in your investigation, you would do a BM levels high. They usually
and if they have pes cavus as well.
Yes, they can have in the later stage of the illness when it progresses. They will have pes cavus as well. But you may get it, you may not get it as well. Okay, so and yeah, these were the most important thing. And then how would you differentiate between ataxia telangiectasia and the Friedreich's ataxia in your
there are telangiectasias in the eye and on the body. Recurrent infections.
Yeah, that's fine, but you cannot say it's more in most of the cases.
I would look malnourished if there would be recurrent infections.
Yeah, recurrent infection is more of a history thing. In your examination, you can't find it. And ataxia telangiectasia is also, it's not easy to pinpoint, to be honest. It's something the ophthalmologists do it. You may find it, you may not find it, but in your examination of your cerebellar, when you are asked to do cerebellar assessment, so there is preserved tone and power and reflexes in telangiectasia.
Sorry?
Okay. There is normal power, reflex, and normal sensation in ataxia telangiectasia, whereas in Friedreich's you get loss of everything. You get reduced power, you'll have a reduced tone. You can have in ataxia telangiectasia as well, but absent reflexes, upgoing Babinski, and you have loss of position and the loss of sensation. Okay.
Yeah.
So that is another point of differentiation between telangiectasia and Friedreich's ataxia. And the other system, as I mentioned, you would you can get a murmur, you can get a hepatosplenomegaly, you'd also do eye exam, you would also tie up the bring ophthalmological assessment for any atopic atrophy, and they also tend to have some abnormal blood sugar as well. So this will be part of your current investigations. Okay, so when we came to investigations, how will you manage? First thing, urine toxicology, substance abuse, blood sugar. You'd be getting full set of obs, and then these tests, and then you go to the the basic blood tests, and you go to neuroimaging.
Yeah. Okay.
And referral to your consultant and your pediatric neurologist, and involving the physiotherapist, occupational therapist, and the other multidisciplinary team.
Okay. Okay, that's good. Thank you, Dr. Rais.
Yeah. So any other? So any questions or any comments, ma'am? If you have got any questions.
No, Dr. Rais, thank you so much. You have explained everything very well.
Okay, I hope that was useful. And yeah, if you, I will try to find the PDF for the examination sequence, and I will share the if I get that list of etiologies. So yeah, in that vindicate etiology, there's no substance abuse. I'm sorry, but you can still use it in most of the cases.
Yeah. And Myra did very well. I think if I was also at her place, I would not able to pick up these things.
No,
But I
yes,
think she's a bit
the
upset about
examination.
that she is not able to do it well.
Yeah.
But I am just telling her, no, she has done it very well. It's like it could. I would also not have picked this. I was also thinking about like this could be.
No. As I said, your examination was full marks. I will give
Yeah.
you full
Just
2 on your examination. You did really well. Your communication and everything was absolutely fine.
yeah.
But the gap was in the clinical reasoning, which was
You know what, Dr.
understandable.
Rais?
Yeah,
When
you
I
was not prepared.
finished my examination, I wrote to Aisha. She was like, "You did well," and I actually wrote that I don't know the DDs.
Okay.
I knew.
No, but I think before we are doing the examination, we should keep thinking in our mind what could be the differential diagnosis, because we should brainstorming at that point of time. Otherwise, in the end, we would be very much, because we won't be getting time na, for summarization and everything.
When will you take our next class, Dr. Rais? And what would it be about? I think it was useful because we tried to cover things today for the neuro and it helped us. So whenever next whatever topic you decide, you can tell us and we can prepare ourselves.
Yeah, even I thought the same, to let you guys know, so that you are preparing a few bits in the starting, and your sessions will be more useful and meaningful, and then you can work on your gaps, rather than coming completely unprepared and then finding yourself in a soup and then going back to preparing from scratch. It's better to do a preliminary um, preparation before the stations. So we can discuss. I can leave the message in the group. But would you guys like any? I mean, what is your preference of choice? I went for neurology because you had mentioned previously that you guys wanted.
Yeah. It was
Neurology.
very helpful for neurology. I think yes.
I think the next sessions, if we take on cardiovascular and PGALs and renal.
Yeah, cardiovascular should be next.
Okay, Shivam.
Dr. Rais, one question I have regarding this one so that we can close it and then discuss about the next class. Okay, so when you asked me to summarize my findings, I gave all the findings. In the end, was it like how to just conclude it? Is it like cerebellar ataxia, or I am suspecting keeping all the all the signs have elicited? I am keeping my differential as Frederick ataxia. What is the
So
closing sentence?
yeah, in your impression, after you made the opening sentence, positive diagnosis, positive findings, and in your um, uh, your impression of where the last point where you'll be listing your diagnosis is that it's more likely to be he's got ataxia, more likely to be um, posterior cerebellar posterior column in origin, a sensory ataxia. It's not a cerebellar.
The dorsal column or posterior?
Sorry, dorsal column.
Yeah.
It's not. So you're differentiating from sensory and cerebellar.
Yeah.
So dorsal column tract, and the it is known as posterior or dorsal column. It is. I think it's the same thing.
Yeah.
Just double check that. It's
The
and
other
and
one is
then
spinothalamic, the one
yeah,
that
that is known as the lateral
yeah.
or the spinothalamic.
Yeah.
Yeah. So you have
I
to
think
mention here
dorsal
that
and
it's a posterior column lesion because of positive rhombus, and then my most likely impression is that it could be Friedreich's ataxia.
Okay.
And the second list will be ataxia telangiectasia.
So this seems to be a dorsal or posterior column tract lesion because of rhombus being positive, and
Yeah.
this could be most likely Friedreich ataxia. Okay.
Yeah, Friedrichs, and then you can list the other.
Kyphoscoliosis and yeah.
Yeah, and you they expect you to give at least 2 to 3 differential. In this case, you can give 2 to 3 differential of
substance abuse.
No, yeah, that is a broad cause for general ataxia. But after you have made you have got the clinical signs of a positive rhombus, then you know it is a posterior column defect. So now you have to give the differential diagnosis of those conditions that involve the posterior column defect. So that will be a proper differential diagnosis, like a relevant differential diagnosis. In this case, you can give vitamin B12 deficiencies as well.
Okay. And subacute combined degenerative.
Yeah, that is secondary to B12. No?
So you can give those things towards the end.
Okay.
Yeah.
But the first would be substance abuse. But first thing.
No, Friedreich ataxia because of kyphoscoliosis.
Kyphoscoliosis, Friedreich's ataxia. But in the management, we would say that we would like to check the urine for any toxicology.
Yeah.
Or,
yeah,
okay.
You can do that. You can mention that. That's reasonable to do that in every child coming in with ataxia.
Okay.